4. So this will be a recapitulation of that and something new, right? I will be going slow and there will be a repetition, but I think as the Zhang's contemporary curve is a new thing, so I will like to deliberate upon it again so as to make it clear to all the PGs and all the practitioners, because this is a practical thing to cover to decrease the primary cesarean section rate in our setups, right? So when does labor becomes abnormal in first stage? So what we have learned since morning, the physiology of normal labor. 6 is the new 4 in active phase of labor, right? I thought there will be a T, but oh, there is no T. So I had made this slide according to that, because you left your patient at 7 centimeter, had a good amount of tea and snacks and came back to labor room. Oh no, she is still 7 centimeter. She's not progressing. This is the common scenario in our labor rooms, right? So what you are ordering? Cesarean section for a protracted active phase, right? So let's see what is abnormal and what is normal. Here we need to see and we need to evaluate your patient again and again. We have to decide upon what is normal and what is abnormal. So the learning objective of the current presentation is the abnormalities of first stage, diagnosis and management. But to know the abnormal, you need to know the new normal. We have talked of new normal, that is the active phase starts at 6 centimeter. There is a lot of controversy, lot of questions by the audience, what to write down in DGO exam, that whether it is 6 centimeter, 4 centimeter or 5 centimeter by WHO. So let's see the normal labor progression. This is very important from all of us. We all know that first stage of labor can be divided into latent phase and active phase, okay? And this is a conventional partograph given in Datta. We are reading it since our undergraduate, our seniors are reading it, and we are still having this in all our textbooks. This is a Friedman's labor curve. You need to know the history of it, that it has been given in the year 1955 by Emanuel Friedman by the study on 500 patients. Remember, 500 patients in a single center in America. Okay, and what he has given 4 phases, that there is a latent phase, there is a acceleration phase, phase of maximum slope, and the phase of deceleration, right? And how does the nulliparous will progress? 1.2 centimeter per hour, 1.5 centimeter in multiparous women in the active phase. This will be the progress, and we all agree to it till date. So I told you only 500. Nowadays, there is a lot of statistical things have come, and we say that is the sample size calculation is appropriate, right? So from 1955 to 68, he has given many good papers, and I don't deny that it was not a good study. They all were very good studies, but still, for the years together, you see 1955 and 2020, it's been years, 70 years or 65 years. There is a lot of change in the obstetric and anesthesia practices. There is a change in the maternal and the fetal size. Maternal age, patient are becoming pregnant first time later at the age. And many obstetrical interventions are available with us. Lifestyle changes are there. There are more sedentary lifestyle females which are coming to our hospital, and more of our monitoring services because we have a stress on the institutional delivery. That's why from 2002 to 2008, Dr. Zhang and his team studied on the labor and has given contemporary labor curve. This word is very important. Don't use Zhang, use contemporary labor curve. We will be conventional partograph and a contemporary partograph. Contemporary, that means a contemporary obstetrical practice, and contemporary labor curve, which has been given by Zhang et al. In the year 2010. And you see this study, in this study, there was a recruitment recruitment of 2.3 lakh patients from 19 medical centers in all over USA, out of which they have seen assessed 62,415 women, right? And more than 88% of women in this study were in spontaneous labor and had normal outcomes. And according to these findings, they have given one graph. This was known as contemporary curve. So what they have seen that from 4 to 5 centimeter, you see, can you understand these graph? This is median and this is 95th percentile. That means mean plus minus 1 standard deviation, which we take it as a normal, right? So they have said that it takes 6.4 hours to change from 4 to 5 centimeters. That is, from 5 to 6 centimeter, it takes 3.2 hours. So 4 to 6 centimeter, it is taking 10 hours. And this 10 hours, previously we were taking as a protracted active phase and taking up for the cesarean section. And why Zhang has gone for this study? Because it has been observed from 1990 to 2010, there was an increase in the cesarean section to 30 to 40%. Then what was the reason? That's why this has been studied. Am I audible? Am I audible? Is it okay?
Yes, you are. Yes, you are.
Okay.
Very clear.
Okay. I'm just confirming, right?
Yes, ma'am, you are audible, ma'am.
Thank you. So
Very
from
much
6 centimeter, it has been taken as an active stage. And you know, this has been told very nicely, elaborately by Dr. Raman. But again, to tell you, from 6 to 7 centimeter, it takes 2.2 hours. And then gradually decreases to 1.5 hours in each centimeter. So it is not a straight line going up. It is a staircase progression or an exponential increase in the dilatation. So if you calculate this 2.2, 1.6, 1.4, 1.8, again, it is coming to around 6 to 8 hours for a nulliparous female. Right? So we need to be seeing this. I'm not going into the details of second stage because that will be taken by another. So we need to see that our females or all over the world, these females are taking more time nowadays for a progress of labor. So can we decrease the primary cesarean section rate by following this? Yes, they have observed we can decrease the primary cesarean section rate by following this protocol. Once in 2010, this has come. There were other authors which have given, and all the PGs here should be knowing what are the landmark studies regarding the labor progression. So one was a Zhang, which was given in 2010. Another was the this Japanese study. And another study was given in 2019, a lapse study in a Norwegian population. Another study which has given from a sub-Saharan countries in Nigeria and Uganda, which was again in 2009 published in, I will be coming to it in later part, in 2018 in PLOS ONE. You see, these all journals are very good journals with a very good impact factor. So we had to rely on these curves. So contemporary curve, as you can see here, what was there in the Friedman's curve? It was sigmoid shaped, but here this was a hyperbolic. And as you can see, this red one is a parous woman and this blue one is a nulliparous woman. You can see there is some inflection point at 6 centimeter parous woman, but there is no inflection point in nulliparous women. That means even after 6 centimeters, these nulliparous women are gradually changing their cervical dilatation, not similar to parous women. Another difference is that there is no deceleration phase. There is no deceleration phase. So these are the 2 points which we need to remember. Then again, according to the time of admission, according to the dilatation at admission, he observed that if the patient is being admitted at 2 centimeter, it takes more time for a delivery. And again, this time, if you see this patient with the red one, 2 centimeters, she has been admitted, and at 5 or 6 centimeters, she reaches in 15 to 16 hours. That means this latent phase is much prolonged than what has been told by Friedman's. So we need to be very careful whenever we are evaluating our patient, whether she is in latent phase or whether she is in active phase. And this was the Zhang patograph. You can click a photograph, or you can go back to your, just type in your PubMed search in a Zhang's, and you will get a 2010 study where this patograph has been given. We are not using this patograph. Rather than, if we want to use a Zhang's guidelines, we should be using the table which I have shown you before. I will be coming to that later on also. So what is there? What is how these lines have been formed? See, these lines have not been formed by a median. It has been formed by a 95th percentile. That means plus minus 1 standard deviation. How many females are falling in this category? So most of the females are falling in this category. It has an exponential like stair lines rather than straight lines, as cervical dilatation is not recorded as a continuous measure. Always remember, these are all statistical models, These are not that every hour you are going to put in your finger and testing that this is. No, these are the statistical models which have been supposed that it will happen after 1 hour, 2 hours, or 3 hours. The progression patterns are more consistent with the physiology of dilatation. Partogram allows much slower labor progression before 6 centimeters of dilatation, but much shorter duration than 4 hours after 6 centimeters. So again, there was a study in a nulliparous Japanese woman. It was a prospective studies, and they have seen that their Japanese women are having much delayed progression as compared to even Zhang's. This was study came in 2010. So what they found in their study, as you can see here, this is a 95th percentile of this Japanese study, and this is a 95th percentile of Zhang's study. They saw that their 95th percentile is falling much ahead of it. So they said the nulliparous labor curve advances more gradually than Friedman curve and was similar to Zhang's curve. The cervix dilated more slowly in the active phase, and it took approximately 5 hours to progress between 10 centimeters compared with 2. This is the study published. I am just showing you because this is the study published in the Lancet Labs study, very famous study. So in a Norwegian population, multicentric prospective study, and they have compared themselves WHO partograph with the Zhang's guideline, and they found there is no increase in cesarean section rate in either group, but frequency decreased from the past. This is a PLOS One, Olapando et al. In 2018, they published the progress of first stage of spontaneous labor in the sub-Saharan African countries. And they have found that their graph is also much similar to the Zhang's curve. And there is no inflection point in a nulliparous female, but inflection point was there in a multiparous female. So coming with this background, which has already been given by Dr. Raman so nicely, to abnormalities of the first stage of labor, because the whatever books we were reading, so difficult classification was there, which have all been changed. So we have an active phase abnormality, we have a latent phase abnormalities. The latent phase abnormality are labeled as prolonged latent phase, and there is no arrest of latent phase. Remember that there is no arrest of latent phase. And in active phase abnormality, there is a protraction disorders and the arrest disorder. I want to tell you the active phase, if you are taking it as a 6 centimeter, there is no other criteria in entering the active phase as such given by the authors. And this 6 centimeter guidelines has been circulated in around 2016 by the government of India to all the CGHS hospitals, we also received in Delhi that we should be following the 6 centimeters as an active stage of labor. I tried to find out that notice, but I couldn't get that notice. So, but still we don't have anything in the WHO. WHO says 5 centimeters. So we have a protraction. Protraction means slowly progressing. Arrest means yes, there is no progress. So this has been on the basis of dilatation, and they have not considered effacement in this. Remember that previous definition of active phase of labor with a 4 centimeter, 50% effaced. This was a guideline with a active phase when we are talking of 4 centimeter, but now they have not considered effacement because we think that at 6 centimeter effacement must be more than 50%. So in coming to causes or abnormalities of stages of labor, I'm not going into the detail because this you can get in any book, passenger problems, passage problems, power problems. I'm not going into the detail of it. I'll pick up only the few important things from this table. This you can get in any book. So I'm not going into death, primipara, advanced maternal age, obesity, diabetes. We all know all these things. So we are not. So what the complication of the first and the second phase abnormalities show? That there can occur if you don't diagnose it properly, increased risk of admission in an ICU, and 5-minute APGAR score can be less than 7. There is an increased risk of operative delivery, cesarean delivery, 3rd and 4th degree perineal tears, urinary retention, PPH, chorioamnionitis, and metritis. See, coming to prolonged latent phase. It's very difficult to define. Why difficult to define? Because you don't know from where to start when your patient has entered in the latent phase. Is it when she entered in the hospital with a pace? Is it that time when she was in the latent phase? We don't know. That's why there is no arrest of prolonged latent phase, right? So criteria for a start of labor is not defined. We say if patient is having regular uterine contractions, 2 to 3 every 10 minutes, lasting for at least 1 hour, then she can be said as in the latent phase. But these regular uterine contractions, as a practitioners, we have seen many a time subside also. Cervical changes not necessary to be present at the start. So shall we take hospital admission for pain? We don't know. And the differential diagnosis is a false labor, which is a precursor of the latent phase. So this is the point, very important, when to define your patient has entered in the latent phase, right? So what are the factors which affects the duration of the latent phase? Unfavorable cervix? Yes. Abnormal fetal position? Yes. Circle arch? Yes. But maternal age, birth weight, pelvic capacity, and gestational time has no contribution in the prolonged latent phase. Neuroaxial anesthesia